Good morning, everyone. The topic for today is chronic otitis media, mucosal variant. Myself, Dr. Ganesh, Assistant Professor from the Department of ENT, Sri Lakshminarayana Institute of Medical Sciences. Moving further, we will be seeing the topic under the following headings: definition, etiology and epidemiology, pathological types, pathological changes, clinical features, investigations, and treatment option. Definition: chronic otitis media is a stage in the disease where there is chronic infection of the middle ear cleft, especially eustachian tube, middle ear, and the mastoid air cell system in presence of a persistent tympanic membrane perforation. This is the WHO definition in case which was given in the year 1998. Epidemiology: among Indian population, 1,000 for rural population, 46% are affected by chronic otitis media in case of rural population, whereas in case of urbans, it is 16% per 1,000 population. This is the gross difference between the rural and the urban population and the prevalence. Coming on to the etiological aspects for chronic otitis media, mucosal variant, you have environmental etiology, wherein environment plays a major role in the development of chronic otitis media. Infective part: previous history of otitis media, iatrogenic causes, genetic and immunological causes, upper respiratory tract infections, allergy, eustachian tube malfunctions. Moving on to the etiological classes. Environmental: low socioeconomic status has been documented as one of the important aspect for development of chronic otitis media. Because of low socioeconomic status, what is happening is there is so much overcrowding over there. There is so much indwelling of this people in and around there. There is so much cross infection. There is more amount of exposure for upper respiratory tract pathogens, leading on to middle ear cleft as well as the middle ear as the nidus of infection for this mucosal otitis media to get developed. Then moving on to the infective etiology, we have few gram-positive organisms. Then we have few gram-negative aerobes, especially with gram-negative predominant. Most commonly, it is the Pseudomonas aeruginosa, followed by Proteus mirabilis, Proteus vulgaris, as well as Staphylococcus aureus. In case of the latest Scott Brown edition, it gives Proteus mirabilis forming 75-95% of the development of this chronic otitis media, Staphylococcus aureus forming almost 40%, and Pseudomonas forming 30%. Earlier edition, they have told Pseudomonas is the one which is predominating, but the latest edition has changed the microbiological picture. Why Pseudomonas aeruginosa in the development of this chronic otitis media? Predilection for moist areas. Pseudomonas aeruginosa acts or sits over the moist areas. The middle ear, as you know, is a six-sided cuboidal structure which is having this ventilation as well as the mucosal clearance. So when there is an infection over here, the Pseudomonas happily sits over there. Then infect tissues by adherence to the epithelial cells by pili or fimbriae. Normal tissues resist such attachment. So what is second thing is like once it goes and sits over there, it attaches by pili or fimbriae, not by normal attachment. So tissue resistance is ineffective, or the resistance provided by the tissues are not sufficient for this to expel the Pseudomonas out. And as well as this cerumen, which is having antibacterial activity, is ineffective against Pseudomonas. So recent studies have shown anaerobes also contribute to the development of this chronic otitis media. Most common anaerobes are Bacillus melanogenus as well as fragilis. Then this obstruction of this air around the granulation. So whenever there is a production of this granulation tissue, what is happening? Obstruction of air around the granulation. This leads to reduction of oxygen, inverse increase in the carbon dioxide, anaerobes multiply. So this acts as the medium or the chamber for this anaerobes to multiply. This is the reason for this anaerobes to predominate. Previous otitis media. What is the commonest cause for the development of chronic otitis media is the previous history of otitis media. Acute otitis media or acute suppurative otitis media was olderly called. 70% of the infants, majority of the time it will heal. But in few cases where there is persistence of inflammation or relapse of this acute otitis media, this acute otitis media will go to a chronically discharging ear. This is the reason for the development of acute otitis media, especially in case of children. Also, the children will have a wider eustachian tube, which is more flatter and more horizontally placed, which is also one of the reasons for the development of this persistence of this infection, leading to acute otitis media, which in turn lead to chronic otitis media. Then we have acute necrotizing otitis media. Acute necrotizing otitis media is a variant of otitis media wherein there is a viral prodrome followed by secondary bacterial infection. Once the bacterial infection supervenes, especially with the pseudomonas, what will happen? There is complete destruction of the epithelium right from the external auditory canal to the middle ear and the mastoid air cell system, leading to complete necrosis of this entire middle ear cleft structures, leading to development of this chronic otitis media. Then chronic secretory otitis media. Chronic secretory otitis media is otherwise called as serous otitis media or blue ear, which is a very common presentation or very common reason for childhood deafness in case of school-going children. And this chronic secretory otitis media is developed because of problem with persistence of this eustachian tubal inflammation. Again, the eustachian tube is shorter, wider, and more horizontally placed. So there is many a chances that the fluid gets accumulated in the eustachian tube, which leads to development of this secretory otitis media. This chronic secretory otitis media can lead to any form of chronic otitis media, not just mucosal. It may lead to squamosal variant also. So this is one of the important etiological aspects with respect to the previous history of otitis media. So acute necrotizing otitis media, where there's a triple prolonged attack. Okay, there is a painless perforation in a short span of time. What is happening is there is a perforation because from epithelium everything is getting eroded. So what is happening is there is a painless perforation in a short span of time. Child with lower general resistance plus virus plus bacteria. This is the triple attack. Child with lower resistance, the immunity of the child which is very less as such. Then there is a super added viral infection, then super added bacterial infection. So poor child with protein deficiency and low immunity, again they are at the risk of developing this acute necrotizing otitis media. Then viral exanthematous fevers are also, and the bacterial causes are bacterial beta hemolytic streptococci, which acts as the reason for this superseded bacterial infection to grow. Areas with poorest blood supply, especially they succumb to toxins. Okay, so in cases of middle ear and the mastoid air cell system, the ossicles as well as the other regions which has poor blood supply, they succumb for the toxins produced by this beta hemolytic streptococci. Then this leads to a perforation, which is painless perforation, which is central perforation, and it is kidney shaped in the area of the pars tensa. Extent of initial necrosis determines the end result. So this acute necrotizing otitis media, as we see, whatever was the extent of the initial necrosis, what is the necrosis which is happening at the initial level, that determines the end result of the same. So what are the grading and severity? So if it is a mild case of acute necrotizing otitis externa, which is confining itself to the pars tensa and usual ASYM process, usually what is happening, the stage of resolution, stage of all those sequelae will happen similar to ASYM, then restoration and resolution of the tympanic membrane to normal. Tympanic membrane heals with a thin scar and remain open, either dry or benign type of otorrhea, which is a COM mucosal variant. If it is a moderate type of acute necrotizing otitis media, the annulus succumbs. Okay, the peripheral annular ligament, the annulus succumbs. Tympanic mucoperiostome is necrosed, ossicles and the bony sulcus are eroded. Healing occurs by ingrowth of meatal skin or the respiratory mucosa of the eustachian tube, leading to cholesteatoma formation. Then on the severe variant, where we have mucoperiostome of the antrum, which is completely getting eroded, dissolved, exposing paired bone over there, deprived of the nutrition. When there is a deprivation of this nutrition, what is happening? There is a formation of the sequestrum, and this leads to development of osteomyelitis. So this will go for bone erosion happening. Eustachian tube inadequacy, eustachian tubal dysfunction, which we have seen already, is due to functional. Most of the time it is functional inadequacy, defective opening, especially patients with cleft palate. For the most common example is patients with cleft palating. They will have functional eustachian tubal inadequacy. Then persistent collapse or collapse of abnormally compliant eustachian tube. Patulous eustachian tube or persistent tubal opening. Again, that is one more reason for the development of this tubal dysfunction. Mechanical, mostly it is of allergic mucosal edema, inflammatory edema, adenoid enlargement, and nasopharyngeal carcinoma. What is happening with respect to the allergy is there is invariably the mucociliary lining which is getting prone for allergy. This leads to allergic mucosal edema. Then we have inflammation, inflammatory process which is subclinically going on. Again, this leads to development of edema, as well as adenoid enlargement. Adenoid enlargement will have obstruction of the eustachian tubal opening at the level of the nasopharynx, leading to the development of tubal dysfunction or nasopharyngeal carcinoma. Again, the nasopharynx is the one where the nasopharyngeal carcinoma enlarges. Initial stages, stage 1 and stage 2 of the nasopharyngeal carcinoma, it enlarges and obstructs the tubal opening, leading to defective functioning of the eustachian tube, especially the ventilatory function as well as the drainage function of the eustachian tube is altered, leading on to middle ear inflammation as well as a chronic otitis media. Iatrogenic perforation due to ventilation tube insertion in case of secretory otitis media. The treatment option for the chronic secretory otitis media or the GRU ear or the secretory otitis media is insertion of the ventilation tube. Okay. So what is happening once there is ventilation tube, we artificially make a nick in the tympanic membrane. We expel out the fluid from the middle ear, then we insert the tube. 50% of the ear suffer at least one episode of otorrhea. After tube ventilation tube insertion and removal, what is happening? 50% of the ear suffer at least one episode of otorrhea. 3% persistent discharge for more than 6 weeks of duration. Residual perforation rate due to exclusion of the ventilation tube. Short-term residual perforation is seen in somewhere around 2 to 3%, whereas long-term residual perforation is seen in somewhere around 47 to 50%. So almost 50% of the year will have a residual perforation. This is one of the major reasons for the development of chronic otitis media mucosal variant. Especially there is a iatrogenic perforation made at the level of pars tensa for draining the serous otitis media. Other causes genetic, increased in Eskimos and the Native Americans. For unknown reasons, Eskimos and Native Americans are at the risk of developing this chronic otitis media. Difficult to answer due to confounding factors. Immunological hypogammaglobulinemia. There is the defective immunoglobulin levels, which leads to development of this chronic otitis media. Then immune suppression, especially HIV. HIV and AIDS are one of the important major key factors for the development of chronic otitis media, especially in patients who has been immunosuppressed. Other causes, upper respiratory tract infection, not studied scientifically, but this has been postulated as the one of the reasons for the development of this chronic otitis media. Also affects the mucosa of the middle ear, less resistant to the organism. Bacterial overgrowth in the middle ear. Allergy also has been postulated as the development of this chronic otitis media. To be proven, allergic individuals have higher incidence of chronic otitis media. Eustachian tubal malfunction. Eustachian tube is blocked by the edema, patulous and allows nasopharyngeal secretions. Down syndrome and cleft palate, especially tensor veli palatine muscles are hypoplastic, and the initiating factor or the result of COM is not known. So tubal malfunction is by blockage by the edema, patulous by the nasopharyngeal secretions, and defective tensor veli palatine muscle, leading to defective clearance of this secretion. GERD, gastroesophageal reflux disorders, has been postulated in the recent times. Why? Because GERD will have chronic laryngopharyngitis. Once the reflux secretions comes into the nasopharynx, then this ascends, it touches the eustachian tubal area, especially over the pharyngeal end of the eustachian tubal area, leading to inflammatory response or evoking inflammatory response. Only anecdotal evidence exists, but it is not proven scientifically. Pathological type, persistent mucosal disease. Why persistent? When we say persistent mucosal disease, why this mucosal disease has to be persistent? What are the reasons for this persistence of the disease? One, it is the persistence of the infection or recurrent infection. These two are the reasons for the development of this persistent mucosal disease. So the focus of infection for the persistent mucosal disease will be in the adenoids, tonsils, and sinuses. Okay, so especially in children who are at the risk of developing this chronic otitis, chronic secretory otitis media, where there is adenoid enlargement, or if there is a tonsil enlargement, or patient is having coexistent sinusitis, they all will act as a nidus for this infection to develop. So this leads to persistent nasopharynx, and the external meatus also plays a role. Repeated infection, mucosal changes. Repeated infections in the middle ear mucosa will have this mucosal changes, formation of a polyp, or formation of granulation, or formation of retraction pockets. All these things has been postulated in the development of the secondary acute cholecystioma, also in the reason for the persistence of this infections. So types of this persistent mucosal disease. So once there is a constant inflammation in the mucosa, what is happening? It may have this mucosal variants, especially you have tubal especially. That means the eustachian tubal area and the opening area and the hypotympanic area is the one which is involved over there. Then we have the tympanic variant, which is called as where in tympanic mucosa, which is edematous and hyperplastic, prolapses into the polyp and it projects as a EAC polyp. Then tympanomastoid, where there is a mucosal changes extending to the mastoid system. So all this has been mucosal only, of which something is limited only with the tubal mucosa, something is going to the tympanic mucosa, something the third variant, it goes into the tympanomastoid system also. Permanent perforation syndrome. You have a defect in the past tensor, the edges of the perforation are healed, so the perforation remains permanent. Okay, this is the second syndrome which happens. So the edges are perforated. There is no chance of reepithelialization happening over there. So this is called as permanent perforation syndrome. Mechanical defect in the tympanic membrane, risk of recurrent infection of the middle ear, which leads to upper respiratory tract infection through eustachian tube or water from the external auditory canal may percolate through this perforation, leading to permanent perforation syndrome. Stages. Based on the duration of the ear discharge, it is divided into few stages. Active stage is one, which is called as when there is a discharging ear up to 3 months. So you have a discharging ear for more than 3 months or so, then it is called as active stage. When you have a quiescent stage wherein there is no discharge for a period somewhere around 3 to 6 months, so it is called as quiescent stage. Then we have inactive stage where there is no discharge at all for a period more than 6 months. Healed means the perforation has healed with the thin tympanic membrane. So these are the few stages in case of chronic otitis media mucosal, where active for less than 3 months, quiescent 3 to 6 months, inactive more than 6 months, and healed means there is a perforation which has healed. So moving on to the clinical features, how the patient will present to you. Usually the symptoms are otorrhea. That means there is a abundant ear discharge. The ear discharge is profuse because there is hypersecretion of the mucosecreting goblet cells of the middle ear, which is going for hyper stimulation. The discharge is profuse. Then the discharge may be mucoid or mucopurulent. Initially, the discharge is mucoid because there is no secondary bacterial infection. Once the bacterial infection supersedes, this leads to mucopurulent discharge, and there may be presence of intermittent discharge associated with upper respiratory tract infection. Whenever there is an episode of upper respiratory tract infection, the inflammation ascends up, so there will be profuse. Once the upper respiratory tract infection settles down and the edema and the inflammation of the mucosa settles down, then this leads to weaning course of this. That's why it is intermittent and it is not foul smelling. There is no bone erosion, so there is no foul smelling. And it is not blood stain. There is no presence of granulation. There is no oral polyp, or there is no periosteal erosion. So there is non-blood staining, and there is a progressive hearing loss. The second most common presentation in case of chronic otitis media is a progressive hearing loss, or it may be a mass. Mass means nothing but a hypertrophied middle ear mucosa, which is protruding out of this perforation, which is called as mass protruding from the middle ear canal. So what are the signs? When looking at the signs of this one, the first and foremost thing we have to look into the perforation. What are the things which has to be seen in case of perforation? First and foremost thing is the type of perforation. The first and foremost, whether it is a anterior perforation, posterior perforation, a small perforation, medium perforation, large perforation. Then the second thing which has to be seen is the edges of the perforation. The edges of the perforation, whether it is a smooth margin or the edges are irregular or the edges are epithelialized, all these things will give clue to how we are addressing the disease. Then number of perforation, multiple perforations are seen in tuberculosis. Then through the perforation, one can see the status of the middle ear mucosa. Whether it is pale, pink or edematous in case of active disease, whether it is edematous, hyperplastic, velvety or polypoidal in case of other presentations. Then coralization, that means the tympanic membrane over there will become thickened due to deposition of this hyaline crystals. This is called as coralization. Also development of tympanosclerosis. It is a patchy opaque deposition of the again hyaline substance on the surface of the tympanic membrane, which is a sign of healed tympanic membrane. Usually the perforation is central. If it is we call it a small when it is involving only one quadrant, when it is medium, which is when, if it involves two quadrants, large if it involves three quadrants. Subtotal, all the four quadrants are involved with the intact annulus, whereas in case of total perforation, all the four quadrants are involved with the even the loss of this fibrous annulus. Fibrous annulus is nothing but the peripheral rim of the tympanic membrane where it is thickened. So in case of total perforation, all the four quadrants of the pars tensa has been involved even with the loss of this fibrous annulus. So this is a diagrammatic view showing the central perforation, which is small in which is involving only one quadrant, which is a medium in case second diagram, which is involving two quadrants. Then it is subtotal involving all the four quadrants. Total perforation, all the four quadrants are involved even with the loss of this fibrous annulus, even with the fibrous annulus. What are the features of this permanent perforation syndrome? Once the perforation is permanent, what is happening? Then this becomes quiescent. That means it becomes inactive for some time. Middle ear mucosa is pale pink, dry, and there is no focus of granulation or keratinization. If it is active, we have profuse discharge. As we said, it is a profuse, non-foul smelling, mucopurulent. Then the tympanic membrane mucosa will be swollen and edematous. The oscular chain usually remains intact and there is no oscular erosion and it is mobile. The oscular continuity is maintained. So this is a various representation showing a dry perforation where we can see the status of the middle ear mucosa in the first diagram. Almost subtotal perforation. We can see about the handle incudostapedial joint as well as the hypotympanic air cells. In the second diagram, we can see the middle ear mucosa is pale, wet, and pinkish in appearance. The middle ear, this diagram is preliminary for showing the middle ear mucosa. Then tubal type. Tubal type is seen in a catarrhal child where there is a presence of anterior perforation and there is profuse discharge. Inflammation of the tubal as peritubal as well as hypotympanic cells will lead to development of this tubal variant. Search for source of infection in the sinus as well as the adenoid. If there is a tubal type, then we have to search the source for the sinus and the adenoids. Tympanic, large perforation with retraction, hyperplastic and edematous mucosa. Oral polyp. Oral polyp is pale, probable, painless, and it is pliable and pedunculated, and it is smooth. Usually it starts from the promontory or the tubal opening, and it may go to the oval window or the round window area. So removal of this oral polyp, end-sac cul-de-sac, will lead to labyrinthitis. Also, if there is obstruction of the tubal opening or the if the oral polyp starts in the tubal opening, it blocks the drainage of the tubes. Flare up with the upper respiratory tract infection and swimming. So the tympanic variant will have flare-ups during upper respiratory tract infection, especially swimming. What is happening? The water percolates through the perforation, leading to development of this infection. History of vertigo, deafness, always suspect labyrinthine involvement. Whenever the patient with the tympanic variant is saying history of vertigo or deafness, then labyrinthitis has to be suspected. The third variant of the persistent perforation syndrome is the tympanomastoid variant, where there is a extension to the mastoid air cell system, representation into the mastoid, pulsatile discharge, especially from the posterior part. So posterior perforation with a pulsatile discharge, that means there is extension to the tympanomastoid system. Severe conductive deafness, poor response to oral toilet, may go for secondary acquired cholesteatoma. These are the patients who always go for secondary acquired cholesteatoma, especially the tympanomastoid variant where there is a posterior perforation. So when you do tuning fork test, clinical examination, or this one, negative on the affected side. Depending on the severity, it can be categorized into mild, moderate, and severe conductive hearing loss. Weber lateralist to the affected side, absolute bone conduction test will be same as that of the examiner. What are the reasons for the conductive hearing loss to develop in case of permanent perforation syndrome? Because of the perforation. Okay, the perforation itself will act as a reason for this conductive deafness to develop. Then healed tympanic membrane with disrupted oscular chain, mucosal changes in the middle ear system. Then the status of the ossicles, oscular discontinuity or oscular erosion also will play a role. Then fluid in the ear with perforation. Whenever there is entry of this fluid into the ear, then they lead to development of tympanomastoid variant of this permanent perforation syndrome, leading to development of conductive hearing loss. Anterior perforation offers no deafness as there is no reduction in the baffling effect. There's one effect which is called as round window baffling effect, which is the nothing but the phase difference which is maintained between the oval window and the round window. So in anterior perforation, there is no baffling, no reduction of this baffling effect. So there is no much of conductive hearing loss. Whereas in case of posterior perforation, more severe deafness due to reduction of this baffling effect. In heel tympanic membrane with disrupted oscillar chain, the maximum conductive deafness which can be seen is somewhere around 60 decibel. Mucosal changes, edema of the mucosa adjacent to the ossicles, mobility is restricted, disease extending to the mastoid, resonance of the mastoid is dampened. All these things are mucosal changes which can happen. For the ossicles, the most common ossicular discontinuity is at the level of the incudostapedial joint. Reduced blood supply or the delicate structure of the incus leading to aseptic necrosis of the long process of the incus leading to dissolution and discontinuity of the incudostapedial joint. The whereas in case of fast this one, there is total separation of the incus from the stapes, whereas in case of slowly progressive disease, deposition of the fibrous tissue which replaces the bone, low frequency sounds getting transmitted, audiogram, conductive hearing loss at high frequency, then low frequency. Sensor neural hearing loss. What are the reasons for the development of sensor neural hearing loss in a patient with mucosal variant? Usually passage of the bacterial toxin across the round window to the cochlea. Okay, then pulling of the oral polyp with bony erosion underneath. Okay, whenever we try to pluck the oral polyp, then this leads to sensorineural hearing loss because labyrinth is involved. Then what are the investigation? Moving on to the further part, investigation, examination under microscope or rigid endoscopy is the confirmatory test or confirmatory for our diagnosis. Then culture and sensitivity. If the patient is in the active stage, we can go for culture sensitivity of the ear discharge. Patch testing is nothing but application of a thin paper, butter paper over the perforation to look for whether how much is the hearing improvement. So we can roughly predict what is the surgical outcome of the patient. This is again a test which is done at the OPD basis. Then we have the pure tone audiometric assay, wherein we assess the hearing at the specific frequencies. Then bilateral X-ray mastoids, then HRCT temporal bones, bilateral HRCT temporal bones, then eustachian tubal patency testing. All these things has been formulated as the investigations for the development chronic otitis media mucosal variant. Photomicroscopy. Why we need to go for the photomicroscopy? To see the margins of the perforation, to see the middle ear mucosa, to see the status of the ossicular chain, to rule out the ingrowth of the epithelium, to see granulation or polyp, to see any evidence of cholesteatoma, for collection of ear swab for sensitivity. All these things are the reasons for which we go for photomicroscopy or photoendoscopy. Rigid endoscope. Usually we use 0-degree rigid endoscope, which was proposed by Mir and his colleagues in the year 1967. The advantages of rigid endoscope over the microscope is to visualize the anterior recess, detailed anatomy of the middle ear through the perforation. Suppose if the perforation is a subtotal perforation or a total perforation, through the perforation we can insert the 0-degree endoscope into the middle ear mucosa, so we can have a detailed anatomy of the perforation. So this is the pure tone audiogram assay showing mild conductive hearing loss in the right ear, whereas case of severe conductive hearing loss in the right ear with large airborne gap. So the conductive hearing loss airborne gap should be more than 20 decibel. So for a larger airborne gap, which suggests there is ossicular discontinuity. Patch test, again, which is performed as a OPD procedure. The materials used are cigarette paper, tissue paper, or gel foam, or butter paper. PTA done before, after the repeat patch testing. Hearing inputs, that means ossicles are intact versus ossicular disruption. So when we do patch testing, after patch testing, if there is an improvement in the hearing, that means the ossicles are intact. Or if there is a worsening of the hearing, that means what is happening, the ossicles are disrupted. Radiological assessment, usually what we'll do is last lateral oblique view, which is 15-degree view in the sagittal plane, X-ray of the skull parallel to the film, and the X-ray beam is projected at 15-degree cephalocaudal region. What we have to see is looking for the bony external auditory meatus on the one side, then followed by the key area of the mastoid, which is nothing but the attic additus and the antrum. So the largest single common air cell which is seen in the X-ray mastoid is the mastoid antrum. So we always look for the honeycombing of the pattern. The three patterns which are described with respect to the X-ray mastoids are the pneumatic mastoid, sclerotic mastoid and diploic mastoid. Pneumatic means the air cells are intact, whereas in sclerosis means the air cells are has been replaced with fluid. Diploic means both are in together. Then reading of the X-ray mastoid, whether it is a region plain or contrast X-ray mastoid, nose or this one, which view of the mastoid, important anatomical landmarks, pathological findings, and the diagnosis. So types of pneumatization, as we said, it may be cellular, well pneumatized, or acellular sclerotic, or diploic mastoid. Position of the dural plate and the sinus plate has to be seen. Presence of bony destruction has to be seen. Presence of mastoid cavity has to be seen. Presence of cholesteatoma or the cotton bull appearance in the mastoid, X-ray mastoid, or all these findings has to be seen when reading the X-ray mastoid. The other views for the X-ray mastoids are Schuller's view, Stenver's view, Towne's view, transorbital view, full view or submento, occipital view. All these things has been other views for the X-ray mastoids. CT scan anatomy of the temporal bone can be more effectively demonstrated with a higher resolution contrast tomography. Detection of the intracranial complications should include at least 2 projections. Okay, so the eustachian tubal patency has been tested by Valsalva. Eustachian tubal and the middle ear has been inflated by forceful closed expiration. Patent eustachian tubal functions has been described. Then the other way of describing eustachian tubal patency is by polysterization. One of the rubber tube is in the one nares, on the other end into the airbag. Other nares compressed with the fingers. Positive nasopharyngeal pressure transmitted to the middle ear. Toynbee test is with swallow the saliva with nose closed. Middle ear pressure increases and then decreases. We can see the movement of the tympanic membrane. So moving on to the treatment. Once we diagnose, once we look for the tubal patency, our aim is to arrest the disease, secure the condition to allow the tissues to the normal. So what are the treatment options available? First and foremost thing, we can go for oral toileting. Oral toileting is by use of cotton buds. Fluffy attached to the Jobson probe removes liquid easily. Dry mopping of the discharge can be done. Debris removal is very difficult, but anteroinferior, which is difficult to clean, can be done. Fear of infection, hence sterile. It has to be sterile. Browning in the year 1984 has demonstrated 85% of cessation of the discharge with active, proper, sterile oral toileting alone. Then we can place a wick, which is called as depot delivery system. Then we can go for suction aspiration, which was first described by Verovan and his colleagues. This is the most common technique, most popular techniques. Breaks down the pocket of infection and allows the drainage. Needs expertise. General anesthesia is required usually in case of children, and if there is accidental injury into the inner ear structures, they may go for vertigo. So suction aspiration has to be very meticulous. Then syringing practiced in some centers which is not routinely uh, advocated to the patients. Materials are usually 1% acetic acid or physiological saline or water with white vinegar. Can remove the debris easily. The advantages of doing syringing is it removes the debris easily. Then there are chances of cross infection and vertigo due to temperature change as well as inner ear stimulation. Then topical antimicrobials has been used. They have antiseptic action. It provides acidic medium, aluminum acetate, spirit, and phenol, which has the acidic medium, which prevents the growth of the bacteria. Then we have antibiotics, especially beta-lactam antibiotics, penicillin, which is discontinued these days. Then chloramphenicol has been used, aminoglycosides, especially your gentamicin, or fluoroquinolones, especially ciprofloxacin, ofloxacin, all this has been used for topical. This one. The displacement system, which is mentioned over here, we have to give intermittent pressure on the tragus so that what is happening through the perforation, the drug will go into the middle ear mucosa. Also, it comes into the eustachian tube. This is what is mentioned in the diagram C. Then aminoglycosides, which are used, are neomycin, effective against Proteus and the Staphylococcus aureus, ineffective against gram-negative anaerobes, limited action against Pseudomonas. Polymyxin, effective against Pseudomonas, ineffective against gram-positive organisms. Quinolones, which are commonly used, are ciprofloxacin and ofloxacin, which are active against Pseudomonas, Haemophilus influenza, and Mycophalus capillaris, and MRSA are resistant. Oral antibiotics start on broad spectrum antibiotics till culture sensitivity report comes. Usually aminoglycosides, lack of activity. Quinolones, excellent anti-pseudomonal activity. So we prefer quinolones third generation or second generation quinolones. So the points to ponder are the principles involved for various techniques to and can apply to the moist areas and position of the defect. Large perforations are more difficult to close as they are more difficult to stabilize and have a smaller recipient blood supply. Very small perforations may be providing a ventilation into a naturally poorly ventilated tube. Freshening of the margins is very important. Application of fine elastic sheet, oil silk or a tissue paper to cover the defect is one of the important aspects. Pre-operative CT, it is done to determine the extent of the disease, temple bone pneumatization, anatomical variations, especially a low-lying dura, low-lying tegment, and a forward-lying large anterior or forward-lying sigmoid sinus, anomalous facial nerves. All these things has been looked up in the preoperative CT. For permanent perforation syndrome, for smaller perforations, you can use cautery. For medium to large perforation, if the airborne gap is less than 40 decibel with no oscular involvement, you can go for meninoplasty. If it is more than 40 decibel, you can go for Tympanoplasty. Cautery, the cautery material used are topical anesthesia of margins with 4% xylocaine. Then small bead of cotton is tightly wound at the end of the applicator, which is the cautery material which is used is your trichloroacetic acid. Stroke inward to outward, right? 0.5 millimeter wide cautery's margins usually should be visible. Repeat weekly, so new spring growing margin can be seen. This is with the help of your trichloroacetic acid. Then surgical principle, the principle for the surgical management to eradicate the disease and promote healing. Then to prevent recurrence of the infection, to prevent complication, and to restore the functions of the middle ear. These are the principles which guide the surgery for the patient. So of which eradication of the disease and restoration of functions are foremost principles. For the tubotympanic variant or the tubal variant of the persistent mucosal disease, meninoplasty after puberty, if the perforation does not heal, is the option. For the tympanic variant, removal of the oral polyp, snare is not recommended. Repair of the ossicles, and then cortical mastoidectomy if there is a persistent discharge. For the tympanomastoid variant, cortical mastoidectomy with tympanoplasty is the most preferred way of dealing with the patients. What is the difference between a meninoplasty and tympanoplasty? Meninoplasty is nothing but a reconstruction of the perforation of the tympanic membrane, assumes normal middle mucosa and the ossicle. Tympanic membrane is not elevated from its sulcus. Whereas in case of tympanoplasty, it is to eradicate the disease of the middle ear and to reconstruct the hearing mechanism with or without tympanic membrane grafting. Also, it includes addressing the middle ear pathology, especially cholesteatoma, adhesions, ossicular chain problems, and it also helps in elevating the tympanic membrane from this sulcus. Tympanoplasty was described by Williston in the year 1952. Much earlier, Berthold and Tagman predicted the meninoplasty. As defined by Williston in 1952, it is tympanoplasty is an operation whose goal is to absolute healing of the aerated spaces of otobase from the eustachian tube to the cells in the occipital bone and the pyramid. It is applicable to any inflammation, trauma, or benign neoplasm and includes reconstruction of the optimal system of the middle ear for function in one operation. It is tailored to the type and the extent of the disease. Basically, the approaches to the ear are permeatal approach, endoral approach, and postoral approach. Postoral approach gives excellent excellent view for the anterior recess. Fascia is also easily accessible. We have various this one. Criteria for a functioning middle ear: intact elastic tympanic membrane, a ventilated middle ear space, mobile and unobstructed oval window or the round window, and mechanism to link tympanic membrane to the oval window has to be managed. Indications for surgery: conductive hearing loss for more than 30 decibel in a ear with good cochlear reserve, progressive hearing loss due to chronic middle ear pathology, perforation or hearing loss persistent for more than 3 months due to trauma, infection, or surgery, inability to take bath or participate in the watery sports safely. All these things has been indication for performing surgery in case of mucosal variant. Absolute contraindications: it's a dead ear, poor cochlear reserve, malignant neoplasm of the external ear or the middle ear with the fibrocystic sclerosis, iatrogenic cholesteatoma, or it is the only hearing ear, or intracranial complications which are arising. All these things has been postulated as contraindications for surgery. Relative contraindications are acute exacerbation of CSYM, dysfunction of the eustachian tube, then chronic external otitis due to Pseudomonas, Aspergillus, and Staphylococcus, patients less than 5 years of age. So all these things are relative contraindications for performing surgery. Prerequisites: dry ear and there is no disease in the ear, there is no predisposing factors. Audiometry and tuning fork test shows bone conduction better than air conduction, adequate cochlear function, patent eustachian tube, oscular chain continuity is preserved, and normal middle ear mucosa is present. Then what are the types of surgeries? You can have tympanoplasty types with sound pressure transformation, sound pressure protection. So for sound pressure transformation, we basically transform the sound. In type 1, hearing is achieved by anatomically and functionally intact lever mechanism. In type 2, abnormal reconstructed hearing mechanism has been restored. In type 3, hearing is achieved without a lever mechanism but with sound pressure transformation via a columnar system, which is called as meningostepidoplexy. In type 4, hearing is achieved with sound protection. Okay, and in type 5, the middle ear cavity is closed and the hearing is achieved by sound protection for the round window with simultaneous obstruction of the oval window. What are the graft materials which are used for tympanoplasty? You have autograft, we have full thickness skin graft as well as split thickness skin graft. Initially, we will have good results, subsequent deformation and infection with high delayed failure rate. Canal skin similar to split skin graft. We can also use fat, we can also use vein graft, which is shear graft. Then we can also use fasciolata, we can also use periosteum, or you can use cartilage, especially tragal cartilage as well as the tragal perichondrium. Temporalis fascia, which was proposed by Heerman and his colleague Strauss in the year 1960, obtained of any size, thickness is same as that of the normal tympanic membrane, provides good resistance to infection, no separate incision is needed, and the metabolic rate is low, or it is almost biologically equivalent to that of the tympanic membrane. Homografts available are tympanic membrane, cadaveric fascia, and vein graft. Dural grafts, excellent success similar to the fascia. Theoretical risk of infectious disease transmission, especially prions, low viral disease, and availability. How well we are procuring the dura is the question. The technique which are used for covering the tympanic membrane is especially overlay technique as well as underlay technique. Overlay technique is called as lateral grafting. Underlay technique is called as medial grafting. Post-oral incision is taken. Harvesting of the temporal fascia is done. Then elevation of the vascular flap or the pedicular flap is done. Ensure complete removal of the tympanic membrane epithelium. The edges of the perforation are freshened so that the epithelialization happens. Then shaping of the fascia to the graft. The temporalis fascia harvested is taken and it is reshaped so that it goes and sits over the residual tympanic membrane, replacing of the canal skin. The canal skin which was taken initially has to be replaced, and then it is closed with bandage dressing. The complications are infection. Poor aseptic technique will lead to infection. Prior contamination or graft failure is associated with post-operative infection. The reasons for graft failure are infection, inadequate packing, especially of the anterior mesotympanum, inadequate overlay of the graft with the remnant tympanic membrane or remnant, which is leading to underlay technique. Oscilloplasty. Oscilloplasty is nothing but a procedure which is involving reconstruction of the oscular chain. Hall and the Reitner performed the first autologous oscular reconstruction. It was in the year 1976. The introduction of the plastipore was used. Then in 1979, ceramic implants with hydroxyapatite. Graft are the synthetic implants, no foreign body reaction, no extrusion, no biodegradation, no ankylosis with bony walls of the tympanum. Maintain acoustic transmission, no newborn formation or evidence of inflammation. This is the PARP and the TOR processes which has been placed during your oscular reconstruction. Summary of the operative procedures: we have cortical mastectomy, radical anterior tympanostomy, posterior tympanostomy, and combined approach mastectomy. Whereas in case of reconstructive side, we have meningoplasty, osculoplasty, and tympanoplasty. Cortical mastectomy for the short-standing chronic otitis media cases where otorrhea is believed to be due to mastite reservoir. Whereas in case of modified radical mastectomy, extensive so as to require complete amputation and it's possible to restore the function. It's a historical precursor of the tympanoplasty. Combined approach mastectomy, anterior tympanoplasty, access to the tympanic cavity by reflecting posterior meatal wall, skinny, that is in continuity with the membrane. By this, it is possible to inspect round window or if oscular chain is damaged for osculoplasty. Whereas in case of posterior tympanotomy, access to the anterior aortic antrum and the facial recess. This completes the topic of chronic otitis media mucosal variant. Thank you for patient listening. Thank you all.